Dr. A. Narumalar. She will be talking to us on thickened endometrium-all scenarios. Madam is from the Vijay Nursing Home, Madurai. Over to you, madam.
Thank you, madam, for your kind words. Happy good afternoon to you all. I thank the Italian Menopause Society and the Indian Menopause Society for giving me this wonderful opportunity. I thank Madam Revati Janaki Raman, Madam, our founder president, Madurai Menopause Society, for giving an inspiration for this group. Now coming to the topic. So, coming to the topic, thickened endometrium. The endometrium is a dynamic target organ that is regulated by the hypothalamo-pituitary axis, and there are cyclical changes occurring in endometrium mediated through estrogen and progesterone. Not audible. Okay. And we all know that there are estrogen and progesterone receptors in the endometrial cells and nuclei. These changes occur either the patient might be in the reproductive age or in the menopausal phase of life. So how are we going to assess the endometrium? The transvaginal ultrasonogram is the first modality of imaging, and we are all doing it day in and out. The endometrium while assessment is done in the midline sagittal plane, and we have to see that the endometrial canal is in line with the endocervical canal. We have to measure the thickest part of the endometrium. See that we are not too close to the fundus near the uterine cornu, and it is measured as an endometrial echo complex from the basal layer of the endometrium through the endometrial canal to the other endometrial layer, and it is better to measure the thickness in the post-menstrual period or around the peri-ovulatory period, so as that we do not miss any endometrial pathologies. So just to recollect, the endometrium, this is how it looks. The first one, in the menstrual phase, it is a bright thin echogenic stripe. There may be some fluid in the canal during menstrual phase. In the late proliferative phase, we know it is a trilaminar structure. Due to the edema of the functional layer, it is an echogenic layer. It is an echogenic layer. We have the basal layer that is echogenic, followed by the hypoechoic functional layer and the central bright stripe in the middle. In the secretory phase, it is an uniformly echogenic secretory endometrium that is due to the edema of the functional layer. And we have the posterior acoustic enhancement also. So the normal range we all know that in the menstrual period and in the early proliferative period it is about 2 to 4 millimeters. In the early proliferative phase it goes up to 7 millimeters. Around ovulation it is 11 millimeters, and in the secretory phase it goes up to 16 millimeters. Whenever we see an endometrium in a patient following a dilatation and curettage or a spontaneous abortion, it is usually less than 5. Anything more than 5, we have to look for any return products. So, how is it in an endometrial hyperplasia? An endometrial hyperplasia, the ultrasound is a diffuse, echogenic, homogeneous one. There is a well-defined myometrial interface. It is this that differentiates it from endometrial carcinoma. In an endometrial carcinoma, it is heterogeneous, irregular. There may be polypoid masses. There may be fluid intrauterine fluid collection, and there is invasion of the myometrium, frankly. So even in young individual who are PCOS, obese, if we see an thickened endometrium, we need to do a endometrial evaluation. So what is the endometrium like in a premenopausal woman? A premenopausal woman presenting to us as with AUB, we see a diffuse thickening of the endometrium. We can take in the secretory phase 16 mm as the cutoff. Why? But if at all in an obese individual or a diabetic, the endometrium may be only 11, but still we need to do an endometrial evaluation because the risk of pre-malignant and endometrial pathologies increases by 25%. So the ideal cutoff is we recommend an endometrial biopsy whenever the RET is more than 12 in a premenopausal woman and more than 5 in a perimenopausal woman with a history of erratic menstrual bleeding. So we can combine a power Doppler to the transvaginal sonogram so that we can the diagnostic accuracy of differentiating from benign to malignant is useful for us. We see a single vessel pattern in an endometrial polyp. We have a multiple vessel pattern in an endometrial carcinoma and a scattered vessel pattern in an endometrial hyperplasia. Either it be an ACOG opinion or the UK NICE guidelines 2018, we see that women with complaints coming and we diagnose as AUB and who is 45 years and above, or 45 years and below with history of PCOS, obesity, diabetes, it's better we go for an endometrial biopsy. So also the UK NICE guidelines says that women representing to us with an infrequent vaginal bleeding, an unscheduled bleeding while on tamoxifen, a PCOS woman, a woman who is not responding to our medical treatment, go for an endometrial evaluation. So how does a postmenopausal endometrium look like? A normal postmenopausal endometrium is just less than 3 millimeter, a thin homogeneous echogenic stripe. This is due to lack of estrogen. So in a woman with a thin endometrium, if she is asymptomatic, less than 4 postmenopausal, we needn't do any evaluation further. But still, a woman with a thin endometrium less than 4 who has got an erratic bleeding, we need to investigate them so as to rule out a type 2 endometrial carcinoma. We know that it occurs in an atrophic endometrium. So what if a woman is on tamoxifen? We all know tamoxifen is a selective estrogen receptor modulator. We know that a woman on tamoxifen will she will come across so many endometrial changes, either a polyp, a hyperplasia, or a carcinoma. And we see that these changes within a period of 6 to 36 months, 50% of the women on tamoxifen develop these changes. And we know that about their endometrial carcinoma risk is 2 to 3 times more in a person taking tamoxifen. And so a women planned for tamoxifen therapy has to be analyzed pre-treatment with the TVS or an endometrial biopsy. So another thing is a women on tamoxifen, this tamoxifen causes a subepithelial stromal hypertrophy. That's why we have a thickness. So normally though the recommendation is women on tamoxifen 5 mm is taken as a cutoff, but still 50% of the women on tamoxifen have normally an endometrial thickness of 8 millimeters. So they say women on tamoxifen, if they come to us with symptoms, with vaginal bleeding, she's got an irregular bleeding, we need to evaluate. Otherwise, we needn't bother. So what's the prospect when she's on HRT? Women on HRT, asymptomatic women, 8 mm is taken as the cutoff, and post-menopausal bleeding, women on HRT, 5 mm is it cutoff, but still a cutoff of 8 to 11 has been suggested in certain studies, and they say that the risk of carcinoma is 7% where endometrium is more than 11, and in one study they said endometrium of less than 11 only 0.02% of percentage had endometrial carcinoma. So coming to the histopathological part of it, endometrial hyperplasia is irregular proliferation of the endometrial gland causing an increase in gland to stromal ratio leading to various histopathological changes and atypical changes in the nuclei and cells. And why we are bothered about endometrial hyperplasia? Because of its propensity to progress to endometrial cancer. So we all know this is due to the increased estrogen unopposed by progesterone. These stimulates the endometrial cells by binding to the estrogen receptors present in the nuclei of the endometrial cells. The incidence is somewhere between 133 per 1 lakh women per year worldwide, and it has been found that the median age at which we find an endometrial hyperplasia is 50 to 54 years, and they have been found that the incidence of atypical hyperplasia is somewhere between, they see more incidences in the 5th decade of life. And finally, they say endometrial hyperplasia is 3 times higher than the incidence of endometrial hyperplasia. So what are the risk factors? Age, an increasing age, nulliparity, obesity. We all know obesity is associated with insulin resistance, and we know that there is increased aromatization, the conversion of androgens to estrogens in the peripheral fatty tissue. Genetic, diabetes mellitus. In diabetes mellitus, again there is insulin resistance and many hormonal changes leading on to endometrial hyperplasia. Anovulatory cycles like PCOS and perimenopause, we know there is more of estrogen, there is positive progesterone. Then estrogen secreting ovarian tumors like the granulosa cell tumors, they are at increased risk. And so also we have been talking about HRT. Estrogen alone, HRT is more prone for endometrial carcinoma, and so also the long-term tamoxifen therapy. Nowadays, even renal transplant individuals, immunosuppression infection has been found to be associated with hyperplasia. So these are all the what I explained. So the presentation, we all know a heavy menstrual bleeding, an irregular bleeding, an unscheduled bleeding on HRT, a postmenopausal bleeding. So how do we classify endometrial hyperplasia? So we don't no longer say simple and complex. According to the WHO 2014 classification, they say number 1, hyperplasia without atypia. Number 2, hyperplasia with atypia. That is atypical hyperplasia. This atypical hyperplasia can be interchangeable with EIN, endometrial intraepithelial lesion. So how are we going to diagnose endometrial hyperplasia? We all know. So the diagnosis is based on the histological examination of the endometrial tissue by endometrial biopsy. We can do it as an outpatient method by the Pipelli biopsy, or we can do a hysteroscopic biopsy in cases where the sampling is non-diagnostic or if it fails, or in polyps. So transvaginal ultrasound definitely has a role in diagnosing endometrial hyperplasia, and hysteroscopy, as I said, can be undertaken whenever we find a polyp or whenever we see a discrete focal lesion. We can do hysteroscopic biopsy. And according to the evidences, they say there is insufficient evidence for evaluating an endometrial hyperplasia with CT or MRI, or doing biomarkers. Biomarkers like phosphatase tensin homolog, beta cell lymphoma protein, and beta cell lymphoma protein 2,4. All these are being recommended, but it's not. There are insufficient evidences regarding the biomarkers. So how are we going to treat? It has been found that endometrial hyperplasia without atypia, only 5% of the individuals over a period of 20 years can go on for an endometrial cancer, and so we can give a proper follow-up with treatment. First, we can address to the reversible factors like obesity, HRT. We can address to that, keep the patient in observation, and if she is not improving or she is having a symptomatic AUB, we can go for treatment. What is the treatment? We go for progestogen therapy. The levonorgestrel releasing intrauterine system is the first line of treatment. For those who decline this, we can go for a continuous oral progestogen therapy. Cyclical progestogen therapy is less effective. And so what is the progestogen we use? We can use medroxyprogesterone acetate 10 to 20 milligram per day, or norethistierone 10 to 20, and this is 10 to 15 milligram per day. So as I said, cyclic progestogens are less effective. So what is the duration we have to give for people taking treatment with progestogens? Hyperplasia without atypia, we have to give for 6 months. Review the patient at end of 6 months and look for the regression. And if the findings are that histopathologically she has regressed and she is not desired about fertility, if at all she is on LNG-IUS, we can retain the LNG-IUS for another 5 years. Otherwise, we have to follow her up again after 6 months. If after two 6-monthly negative sample, we are safe and we can discharge her from treatment. Whenever we give her on progestogens, we have to advise her, tell her to report to us if she gets a vaginal bleeding after completion of treatment. So who are the ones that we have to go for a surgical treatment? Women treated with progestogens, hyperplasia without atypia, or completed the treatment, 12 months of treatment is not regressing. A patient who has gone on to atypical hyperplasia after 6 months of therapy, or she's having bleeding symptoms, or she's declining in endometrial surveillance, we can go for a total abdominal hysterectomy with bilateral salpingoophorectomy in a postmenopausal women. In a premenopausal women, we can do a TAH with bilateral salpingectomy. So we all know a lap approach will be, a laparoscopic hysterectomy will be better for the shorter stay in the hospital and better pain relief. And we all know that endometrial ablation is no longer recommended because we are not able to have a complete and persistent endometrial destruction, and we won't be able to do a further histological surveillance later. So what's the treatment of atypical hyperplasia? Atypical hyperplasia, the treatment is total hysterectomy with bilateral salpingoophorectomy for both premenopausal and menopausal. We go for a hysterectomy. But if at all they are not reluctant to have a hysterectomy, then we need to follow them closely and advise them about the risks of going on for endometrial carcinoma. So if a patient is on HRT and she is having a endometrial hyperplasia, if she is on a sequential regime, we have to advise her to go for a LNG-IUS, or we can ask them to continue a continuous combined HRT. So if at all she is on tamoxifen, what advice we should do? Tamoxifen, women taking tamoxifen, as I said already, she has every other chance of getting
hyperplasia and cancer. So a woman on tamoxifen, if at all she has any bleeding, abnormal bleeding, she has to report to us immediately. We see that women taking other aromatase inhibitors like anastrozole, exemestane, and letrozole, they are not at increased risk. And we see that this LNG or AUS prevents polyp formation and reduces incidence of endometrial hyperplasia. So polyp, we have to remove the polyp and do a background examination of the endometrium and follow her up based upon the histopathological report. So this is the algorithm. So this what all I have said comes under this. Women, pre or perimenopausal women presenting to us with AUB after checking her whether she doesn't have any blood parameter abnormalities, no pregnancy complications. We have to look at age. Women less than 45 with a family history of anovulatory AUB like PCO, diabetes mellitus, hereditary non-polyposis colonic cancer, go for a biopsy. Women more than 45 years not responding to conservative treatment, go for an endometrial biopsy. Do an endometrial transvaginal ultrasound. If at all there is a focal lesion that appears heterogeneous thickening, go for a biopsy. If there is a history of chronic ovulation, chronic anovulation, and there is a persistent bleeding, but still the endometrial thickness is less than 12 premenopausal, less than 4 perimenopausal, we can go for a conservative treatment and follow her up. If she is not responding, go for a biopsy. Whereas if the endometrial thickness is more than 12 in a premenopausal woman and more than 5 in a perimenopausal woman, do a endometrial biopsy and follow her up. In a postmenopausal woman, we may incidentally find a thickened endometrium. If at all she is on HRT or tamoxifen, we can take 8 mm as the cutoff. If she is not on HRT or tamoxifen, we can take ET up to 11. If it is less than 11, we can observe her, and if there is second bleeding, do a endometrial biopsy. Or else, if it is anything more than 11, we have to do an endometrial biopsy. Whereas, if she is symptomatic, postmenopausal women, we have to rule out any cervical cause, vulval cause, vaginal cause for her bleeding, and then look into the transvaginal, do an ultrasonogram, and if the ET is more than 4, go for biopsy. If it is less than 4, we can avoid it, observe her, and then go for biopsy. So this is how we have to follow up and treat her accordingly. Thank you for the patient here.
Thank you, Dr. Narumalar, for giving a detailed account on evaluation of endometrium at all age groups. 2 points that I wanted to highlight. One is actually there is no upper limit of cutoff in premenopausal women. Though we empirically say 16, if you find a 20 millimeter endometrium in the menstrual phase, you can repeat a scan after menstruation and find out whether it is still thick. Then only we need to sample. Even sometimes women who have conceived in that cycle, we may find an endometrium which may be very bright and up to 20 millimeters. So we can wait for the next period. Yes, second point is in women on tamoxifen, though theoretically we can say Mirena can be used for endometrial hyperplasia in these women, it is not recommended because of the unknown effect of progesterone. Though very small quantity, it is not recommended. So we cannot use Mirena for breast cancer patients who are on tamoxifen. Thank you very much.
Thank you. Anything we need a histopathological result, madam. We have to
disordered proliferative endometrium is histopathology.
Histopathologically, we have to classify it as what I said, whether there is ATPR.
No, it's not considered as endometrial hyperplasia. So it's not endometrial hyperplasia. Every time we get the report, but it's not endometrial hyperplasia. Totally different from endometrial hyperplasia.
This is a little confusing when there is.
It's not a premalignant condition. It is not considered as a premalignant.
Now I request all